Welcome to our latest session in the Radong Smart Review GI Cancer series.
Great to be back.
Today, we're tackling two really dynamic and exciting advancements in rectal cancer management.
Yeah, big topics.
First, how we can potentially spare patients from major surgery through what's called the watch and wait approach. And second, truly transformative power of immunotherapy for a specific subset of these cancers, the mismatch repair deficient ones.
That's right. The whole landscape of rectal cancer treatment has been profoundly altered by Total Neoadjuvant Therapy, or TNT,
TNT, yeah.
by significantly boosting those pathologic complete response rates, the PCR rates. TNT has just opened up these incredible new avenues
Right.
for managing locally advanced rectal cancer. It fundamentally changes how we think about treatment goals and, importantly, patient quality of life.
Absolutely. I mean, the idea that a significant chunk of patients, maybe up to 40% sometimes, can get a complete response and potentially avoid, the morbidity of a total mesorectal excision,
It's
TME.
groundbreaking.
Yeah, it really is. So we're going to explore who's actually a candidate for this non-operative path, what the meticulous surveillance involves, and the really compelling trial data that supports it.
And then, like you said, we'll pivot to something equally remarkable. How immunotherapy isn't just an option, but is becoming a preferred, game-changing strategy for dMMR rectal cancer.
dMMR.
It's offering a whole new pathway that was honestly unimaginable just a few years ago.
Okay, but maybe let's set the stage a bit first. Just briefly touch on the anatomy.
Good idea. Context matters.
So when we talk about rectal cancer, it's inherently complex because of its location, right? The rectum, that final section of the large intestine.
Mm.
It's nestled in a pretty tight space down there in the pelvis,
Yeah.
right next to critical structures, bladder, sexual organs, and of course the sphincter muscles.
Absolutely critical structure.
And this proximity, it means that surgical removal, especially a big surgery like a TME, can come with significant long-term quality of life impacts.
Oh, definitely.
We're talking about things like potential permanent colostomies and issues with sexual and urinary function, things that really affect daily life.
Precisely.
Yeah.
And rectal cancer, it's a significant global health challenge. Incidence rates vary, but it's a big deal worldwide.
Right.
And while we know the established risk factors, age, family history, IBD, things like that, our focus today really is on optimizing treatment for the locally advanced disease we see.
Okay.
Our ultimate goal is improving patient outcomes, not just survival, but crucially, mitigating those long-term side effects.
Yeah. Quality of life.
Exactly.
Right.
Understanding that delicate balance is precisely why strategies like watch and wait and these new immunotherapies are so impactful.
That makes perfect sense. So with those potential morbidities, those side effects, kind of framing the discussion, let's dive into the watch and wait strategy.
Okay.
The main goal, as we said, is sparing patients from that significant TME morbidity. And this approach, it's really reserved for highly select patients. They have to achieve what we call a clinical complete response, or CCR, after their neoadjuvant therapy.
And it's become particularly relevant, as you mentioned, with the higher CCR rates we're now seeing with TNT.
Exactly. TNT really enabled this on a wider scale.
Defining that CCR, though, that's absolutely paramount. It's not a casual thing. It demands a rigorous, multidisciplinary evaluation. You need an experienced team looking at this.
Multi-D assessment, yeah.
The NCCN guidelines are very clear on the criteria. But to simplify it maybe for review purposes, we can think of the key elements as FDM.
FDM. Okay, what's that stand for?
Flexible endoscopy, digital rectal exam, and MRI.
FDM. Okay, that helps. So first, the F-flexible endoscopy. What are we looking for there?
On high-definition flexible endoscopy, the bowel must show basically a pale, smooth scar.
Okay, smooth scar.
No signs of ulceration, no nodularity, no mucosal irregularities, no stricture. It just needs to look completely healed, flat, pale.
Got it. All right, second, the digital rectal exam, DRE.
The DRE needs to be absolutely clean. You're feeling for a smooth, flat scar with no palpable nodularity whatsoever.
Nothing bumpy.
Nothing. It's actually incredible how much information a skilled DRE can provide in this setting. It's low-tech but high yield.
Okay, and third, the MRI.
Right. Pelvic MRI is crucial. Specifically, you need diffusion-weighted imaging, DWI.
Yeah, okay.
It needs to show a fibrotic linear scar. We're looking for low signal intensity on the T2 weighted images.
Low T2 signal.
No diffusion restriction, because restriction would suggest active tumor.
Right.
And critically, no suspicious lymph nodes remaining.
Okay. FDM endoscopy, DRE, MRI, clear criteria. Now here's something you mentioned, an important clinical pearl. What about biopsies? If all three of those look good, do you still biopsy?
That's a great question, and the general consensus now, supported by NCCN, is that if these three FDM criteria are definitively met, routine biopsies typically don't offer any added diagnostic value.
Okay. Why not?
Well, mainly because they carry a pretty high false negative rate in this post-treatment scar tissue. You can easily miss microscopic disease.
Ah, sampling error.
Exactly. And they could also introduce complications, bleeding, maybe infection, perforation risk, although low. So if the FDM criteria point strongly to CCR, we generally avoid routine biopsies in that complete response setting.
Okay, that's a really practical point.
What's also fascinating about the CCR assessment is the timing. It actually varies depending on which TNT sequence the patient received.
Oh, right. Induction versus consolidation.
Precisely. So if you're using induction TNT, remember that's chemotherapy first, then chemoradiation.
Chemo first.
You should wait no earlier than 8 weeks after finishing the radiotherapy to do the assessment.
8 weeks after radiation, why the wait?
It allows for what we sometimes call a delayed response. Radiation effects can continue to mature over time, and the tissue needs time to heal and declare itself. So you give it that extra time.
Okay, 8 weeks post-RT for induction. What about consolidation TNT? That's radiation first, then chemo.
Right. For consolidation TNT, the assessment window is a bit tighter, generally within about a month of completing that final cycle of chemotherapy.
Sooner, okay, within a month of finishing chemo.
Yeah, the thinking there is you've delivered the most potent local therapy, the radiation up front. The chemo is then consolidating that response. So you want to check relatively soon after the full treatment course is done.
Got it. So the sequence matters for assessment timing.
Definitely. Now, what if you don't see a full CCR? Maybe it's a near complete response. Some subtle findings, maybe slight residual thickening on MRI, or a tiny irregularity on scope.
Yeah, what do you do then?
In those borderline cases, you might consider an additional, say, 8 weeks of observation and then reassess.
Watch a bit longer.
Exactly. Sometimes that extra time can tip them over into a true CCR. But, and this is crucial, if a patient doesn't achieve that full CCR after the initial assessment or the extended observation period,
Or if they relapse later.
or if you see any signs of tumor regrowth after an initial response, then radical surgery, the TME, immediately becomes the indicated path.
No messing around them.
No. It's vital to remember that a high degree of clinical suspicion for regrowth based on that FDM assessment, even without a confirmatory biopsy sometimes, is often enough to mandate surgery.
Okay.
We don't want to delay potentially curative, definitive treatment if the non-operative approach isn't working or fails.
Right. The goal is still cure. Okay, that clarifies the watch and wait pathway. Let's shift gears now to pathology.
All right. Let's shift our focus now to a really fascinating and incredibly impactful area of rectal cancer pathology.
Okay.
We're talking about a small but hugely significant subset of rectal adenocarcinomas. It's roughly 5 to 10% of them
5 to 10%, okay.
that are classified as mismatch repair deficient, or dMMR, or you might hear it as microsatellite instability high, MSI high. They often go together.
dMMR or MSI high. Can you just briefly explain what that means again? Mismatch repair.
Sure. So dMMR essentially means a cell's built-in DNA repair system isn't functioning properly.
Okay.
Think of this system like a very vigilant spell checker that proofreads DNA every time it replicates.
A spell checker for DNA. I like that.
Yeah, it's designed to fix tiny errors, especially in these repetitive DNA sequences called microsatellites.
Microsatellites, okay.
When this spell checker, the MMR system, is deficient dMMR, these errors, these typos, accumulate, especially in those microsatellite regions.
You get lots of errors.
Exactly.
Yeah.
Leading to what we call MSI, high levels of instability in those microsatellites. And this buildup of genetic errors is crucial because it has profound implications for how these tumors behave and, critically, how they respond to treatment.
Right. How so? How does it change things?
Well, here's the paradox. Historically, these dMMR tumors actually showed a poor response to conventional chemotherapy.
Oh, worse, not better.
Yeah, which was a real challenge. But here's the game changer. Their very high mutational burden, all those accumulated DNA errors, the typos, they make these tumors exquisitely sensitive to immune checkpoint inhibitors.
Ah, okay.
Because all those mutations generate numerous unique proteins on the tumor cell surface. We call them neoantigens.
Neoantigens, new proteins.
Exactly. Proteins the immune system doesn't recognize as self. It's like the tumor is waving a bunch of flags, making itself highly visible to the immune system.
So the immune system can spot it easily.
Precisely. Checkpoint inhibitors then basically take the brakes off the immune system, allowing it to attack these highly visible tumor targets much more effectively.
Wow.
This understanding has just fundamentally revolutionized their management. NCCN guidelines now fully incorporate these, frankly, astonishing new approaches for dMMR rectal cancer.
Okay, this is where the story gets really compelling then. Let's talk about the evidence supporting these non-operative approaches, both watch and wait, and now this immunotherapy angle.
Yeah, the evidence base is strong and growing. For watch and wait, the concept really was pioneered by Dr. Habergama and her group in Brazil.
Habergama, right, that's the name you'll always hear.
Absolutely, it's a foundational reference. Their initial retrospective report, way back in 2004.
Wow, that long ago.
Yeah, on 71 patients, it was truly eye-opening. These were patients with a clinical complete response after standard neoadjuvant chemoradiation, who, instead of surgery, were just observed.
Watch and wait.
Exactly. And the results were remarkable. 100% 5-year overall survival.
100%.
100%. And 92% disease-free survival for those observed CCR patients. This was a radical idea at the time, but it demonstrated this could be a viable path.
Okay, so that planted the seed. What came next?
Well, building on that, the International Watch and Wait Database, or IWWD registry study,
IWWD?
published by Van der Valk in 2018, this provided real-world validation on a much larger scale, over 1,000 patients.
1,000 patients, okay. That's significant.
It's the largest compilation of data for CCR patients, managed non-operatively after neoadjuvant treatment. And what it showed was an expected 2-year local regrowth rate of approximately 25%.
25% regrowth at 2 years. Okay.
But here's the critical part. Nearly all of those regrowths, 88% of them happened within the first 2 years.
So early failures mostly.
Mostly early. And typically they were endoluminal, meaning the regrowth was within the bowel wall itself.
Contained.
Which makes them relatively easier to salvage, usually with either a local excision or, if needed, the standard radical surgery, the TME.
Okay, so regrowth happens, but it's often manageable. What about survival in the IWWD?
Equally reassuring. The 5-year overall survival was 85%.
85%.
And disease-specific survival was even higher, at 94%.
That's very good.
Yeah. And the probability of staying free from local recurrence was exceptionally high, especially if you maintained your CCR for a year or more.
Oh, interesting.
Yeah, after 1 year of sustained CCR, the chance of recurrence later was much lower, like 97% freedom from recurrence at 3 years, 99% at 5 years if you made it past that initial window.
Wow. So the first year or two are key for surveillance.
Absolutely. The powerful interpretation here is that non-operative management, NOM, is feasible. It's safe in carefully selected patients. You get high rates of salvage for local regrowth, and it doesn't seem to compromise overall survival.
Okay.
It even suggests perhaps that surveillance intensity could potentially be reduced if a CCR is maintained for, say, the first 3 years, though that's still being studied.
Okay, that's encouraging. But you mentioned salvage. What about distant spread? If the tumor regrows locally, does that mean it's more likely to have spread elsewhere?
That is a key clinical concern and a really important question. Does local regrowth impact distant outcomes? A retrospective study from Memorial Sloan Kettering MSKCC by Smith in 2019 looked at exactly this.
Okay, MSKCC data.
They compared CCR patients managed with watch and wait to patients who had a pathologic complete response, PCR, found after they underwent TME surgery.
Okay, comparing watchers to surgical PCRs.
Exactly.
Yep.
Now, the CCR patients who avoided surgery, the watchers, they had excellent rectal preservation. 82% kept their rectum. And local control was also very high, 91%, including those who needed salvage surgery.
The local outcome.
But there was a notable finding. Those patients who did experience local regrowth during watch and wait,
the 25% or so?
yeah, that group, they had a significantly higher incidence of distant metastases later on, a striking 36%.
36%? Wow. Compared to what?
Compared to only 1% distant mets in those CCR patients who didn't have a local regrowth. And also compared to the PCR group who had surgery.
Okay, so local regrowth seems linked to a much higher risk of distant spread. That's concerning.
It is. It really underscores the need for careful and prolonged systemic follow-up, checking for distant disease in all watch and wait patients, even if their local regrowth is successfully salvaged.
Right.
It suggests maybe that regrowth is a marker for more aggressive underlying biology, or perhaps that the initial clinical complete response wasn't quite as complete on a microscopic systemic level. Needs careful watching.
That's a crucial distinction, a really important point about surveillance. Okay, any other key studies on watch and wait before we get to opioid?
Yeah, one more worth mentioning is the Washington University retrospective series by Chin, published in 2020.
Wash you, okay.
This study further supported non-operative management, specifically after using short-course radiation therapy followed by chemotherapy.
Oh, short course RT, interesting.
Yeah, they reported a pretty impressive 51% CCR rate in patients who completed at least 6 cycles of chemo after the short-course RT.
Half the patients got CCR.
Yeah, and 79% of those remained free from recurrence at a median follow-up of about 30 months. And again, reassuringly, all 8 local regrowths they saw in that series were successfully salvaged surgically.
Okay, so more reinforcement for the feasibility, even with different neoadjuvant approaches like short course RT.
Exactly, it adds to the body of evidence.
All right, now let's talk about the big one, the randomized trial that really shaped practice. OPRA?
Yes, OPRA, organ preservation in rectal adenocarcinoma. Garcia Aguilar, published in JAMA Oncology in 2022. With updates later, this is paramount.
Okay, OPRA, what was the design?
It was a phase 2 randomized trial, specifically designed to directly compare 2 different TNT sequences for patients who were explicitly seeking organ preservation.
So the goal was organ preservation from the outset?
Yes. Patients had stage 2 or 3 rectal cancer, initially considered candidates for TME surgery. They were randomized to one of 2 TNT sequences.
Okay, what were the 2 arms?
One arm was induction. That was 4 months of chemo first, FOLFOX or CAPOX,
Chemo.
followed by standard long-course chemoradiation. The other arm was consolidation. That reversed the order.
Radiation first.
Right. Long-course chemoradiation first, followed by 4 months of consolidation chemo, FOLFOX or CAPOX.
Okay, induction, chemonetio, CRT versus consolidation, CRT, editemo. And the key was, what happened if they got a CCR?
Exactly. The key was that patients who achieved a clinical complete response, CCR, in either arm after finishing their assigned TNT sequence were then offered a watch-and-wait strategy.
Okay, so the endpoint wasn't just CCR rate, but actually avoiding surgery long-term.
Precisely, and the results were quite decisive. While the 3-year disease-free survival, DFS, was actually similar in both arms, around 76%.
Okay, survival similar.
The key secondary endpoint, and for organ preservation, this is the one that really matters, was 3-year TME-free survival. Survival without needing the big surgery.
TME-free survival.
It was significantly higher in the consolidation arm, the radiation therapy first arm.
How much higher?
53% TME-free survival at 3 years in the consolidation arm versus 41% in the induction arm.
Wow, 53 versus 41%. That's a big difference. Why? What drove that?
It was largely driven by a lower rate of local tumor regrowth in the radiation therapy first arm. Only 27% local regrowth in the consolidation group compared to 40% in the induction group.
Ah, so radiation first led to fewer relapses locally, meaning more patients stayed TME-free.
Exactly. And the 5-year update, presented by Verhey in 2023, basically solidified this benefit. It showed 54% versus 39% TME-free survival at 5 years, still favoring consolidation.
Okay, that's really clear. Radiation first is better if the goal is organ preservation.
That's the big takeaway.
So what does this translate to clinically, like a pearl?
It translates into a really crucial clinical pearl for practice. Putting radiation first in the TNT lineup for locally advanced rectal cancer maximizes the chance for organ preservation.
Radiation first maximizes the chance.
Which could potentially be achieved in as many as half of all patients.
Half of all patients potentially avoiding TME. That's huge.
It is. This isn't just a sequencing preference. It really suggests that delivering radiation up front might induce a more profound, more complete initial tumor regression.
Okay.
Creating a more favorable biological landscape, maybe, for the subsequent chemotherapy to then consolidate that response into a lasting CCR and enable successful organ preservation. It's a profound takeaway.
Yeah, it really changes how you sequence TNT if watch and wait is on the table.
Absolutely.
Okay, you mentioned other trials quickly. GRECAR2 and TREC. And OPRA. Not OPRA, but OPRA.
Right. Just briefly, GRECAR2 by Roulier in 2020 looked at doing a local excision surgery for good responders after chemoradiation instead of just watching.
Okay, cut out the scar area.
Yeah. It showed about 65% organ preservation, but a fair number still needed a completion TME later, so it highlights there's still debate.
Yeah.
Is pure watch and wait better, or local excision for some?
Okay. N-track.
TREC was focused on earlier stage disease, T1, T3B, and 0. It compared short-course RT, then chemo-wait surgery versus just upfront surgery. For the RT arm, if they had a good response, they offered observation. It showed high organ preservation rates, around 70%, with better quality of life compared to upfront TME.
Okay, supporting organ preservation in earlier stages too. Now, OPRA. OPERA.
Right. Don't confuse it with OPRA. OPRA, by Gerard in 2023, look at boosting the radiation dose.
Ah, radiation boost.
Specifically, adding a contact brachytherapy boost, delivering radiation right onto the tumor surface after conventional external beam chemoradiation.
Brachy boost. Okay.
It significantly increased 3-year organ preservation rates, up to 81% versus 59% without the boost, especially for smaller tumors, T2 or small T3s.
81% organ preservation. That's very high.
Very high. It really showcases how specific, highly localized radiation techniques might further enhance outcomes for selected patients seeking organ preservation, pushing the envelope even further.
Okay, lots of trials, lots of data. Let's try and distill this down. Time for some clinical pearls.
All right, let's hit those high-yield facts, the must-knows for exams and practice.
Pearl number 1, clinical complete response criteria. What are they again?
Remember our mnemonic? FDM,
FTM.
negative flexible endoscopy, smooth pale scar, no irregularity, negative digital rectal exam, smooth, flat, no nodules, and negative pelvic MRI. T2, low signal fibrosis, no DWI restriction, no suspicious notes.
FTM negative. Got it. Pearl number 2.
OPRA outcomes. The OPRA trial showed that a consolidation TNT approached radiation therapy first.
Radiation first.
Achieved significantly higher 3-year TME-free survival, 53% versus 41% compared to induction, chemo first, making consolidation preferred if organ preservation is the goal.
Prefer consolidation RT first for organ preservation. Okay. Pearl 3.
Local regrowth rate. Based on that big IWWD database,
WW, yeah.
expect an approximate 2-year local regrowth rate of about 25% after achieving CCR.
Yeah.
But the good news is most are salvageable.
25% regrowth, mostly salvageable. Pearl 4.
dMMR rectal cancer. This is the game changer. The MSKCC dostarlimab trial
The immunotherapy trial.
showed an unprecedented, frankly, unbelievable 100% clinical complete response rate with single-agent neoadjuvant dostarlimab for dMMR locally advanced rectal cancer.
100% CCR.
Yeah, strongly supporting a non-operative management approach for these specific patients.
Okay. And that leads to pearl number 5.
Pearl number 5, dMMR immunotherapy efficacy and guidelines. Current NCCN guidelines now recommend checkpoint inhibitors like dostarlimab, nivolumab, or pembrolizumab as preferred neoadjuvant or even definitive therapy for dMMR/MSI-high locally advanced rectal cancer, given this profound efficacy.
Preferred therapy now for dMMR. Okay. FDM, OPRA consolidation, 25% regrowth, 100% CCR with IO and dMMR, and IO now preferred NCCN guideline. Got it.
Excellent summary.
All right, let's apply this. Let's revisit our case, Ms. Rodriguez. She's 68, active clinical T3N1 rectal adenocarcinoma, 8 centimeters from the anal verge. And crucially, her tumor testing revealed dMMR status.
Okay, T3N1, dMMR, positive.
And she really wants to avoid major surgery and its long-term side effects. Wants to maintain her quality of life.
Understandable.
So, based on everything we've just discussed, what's the approach for Mrs. Rodriguez?
Well, for Mrs. Rodriguez, her dMMR status is the absolute critical factor here. It changes everything.
Right, because historically,
dMMR tumors responded poorly to conventional chemotherapy. So trying to achieve organ preservation with standard TNT would have been much less certain, perhaps even unlikely, especially with N1 disease. Avoiding surgery would have been very challenging.
okay, but now?
But now, as we just highlighted with Pearl #4, the MSKCC dostarlimab trial, and supported by other studies like NICHE-2 in colon cancer,
Yep.
these have shown truly unprecedented clinical complete response rates, 100% in the rectal cohort, and excellent long-term disease control with immunotherapy alone in this specific dMMR patient population.
Immunotherapy alone, no chemo, no radiation initially.
Potentially, yes.
Huh.
For Ms. Rodriguez, the strategy perfectly aligns with her desire to avoid surgery and its morbidities. It offers her a pathway that, frankly, wasn't even on the map until very recently.
No, so what's the recommended regimen?
The recommended approach, based on NCCN guidelines now, would be neoadjuvant checkpoint inhibitor monotherapy.
Okay, which drug?
Options include dostarlimab, nivolumab, or pembrolizumab, typically given for about 6 months.
6 months of immunotherapy. And then what? What's the post-treatment plan?
After completing the immunotherapy, Mrs. Rodriguez would undergo that rigorous restaging we talked about, the full FDM assessment.
DRE scope, MRI with DWI.
Exactly. If she achieves a clinical complete response, and based on that MSKCC data for dMMR tumors, the probability is extremely high.
Yeah, potentially 100%.
Then she would be managed with a comprehensive watch-and-wait surveillance protocol. The goal is to spare her from surgery entirely.
Wow. So for dMMR patients like her, immunotherapy followed by watch and wait, if CCR is achieved, is now a primary guideline-supported strategy.
It is. It's a highly promising pathway.
Uh,
Of course, we always need the contingency plan.
right. What if she doesn't get a CCR? Or what if she relapses later on watch and wait?
Good point. If she doesn't achieve CCR after immunotherapy, or if local regrowth occurs during surveillance, then standard chemoradiation and NIDOR surgery would absolutely be considered as salvage options.
Okay. Standard treatments are still the backup.
They are. But the hope, and increasingly the reality for many dMMR patients, is achieving organ preservation without needing a scalpel or even radiation.
Truly remarkable. Okay, let's touch on treatment techniques again, summarizing the implications.
Sure. So when we think about treatment techniques, specifically aiming for organ preservation in the non-dMMR population,
Right, for the majority who are MMR proficient.
the choice of TNT sequence is paramount. And OPRA gave us a clear answer there.
Consolidation. Radiation first.
Exactly. The consolidation radiation therapy first approach is superior for patients aiming for watch and wait. It maximizes the chance of TME-free survival.
Okay. And you also mentioned the OPRA trial, the brachy boost.
Right. That highlights how we can potentially push organ preservation rates even higher in selected cases by intensifying the local radiation dose, for example, with a contact brachytherapy boost, especially for smaller tumors after initial chemoradiation. It shows how refining radiation techniques matters.
So optimizing the radiation component is still key for many.
Absolutely. But then, arguably the most groundbreaking shift in technique, or rather strategy,
Yeah.
is for those dMMR tumors.
Yeah.
The realization that immunotherapy can, in many cases, function as a definitive local therapy.
Definitive local therapy, meaning it replaces radiation or surgery locally.
Potentially, yes. It could spare patients from both radiation and surgery entirely. This isn't just an additional tool in the toolbox, it's a completely new paradigm.
Minimal to no invasive treatment.
That's the prospect for a significant subset of patients. It's a testament to how profoundly understanding the molecular biology, the dMMR status, can utterly transform clinical practice and treatment selection.
Amazing. Okay, I think we've covered a lot of ground. Ready to put our listeners to the test.
Let's do it. Board blitz time.
All right. Case 1. A 72-year-old patient has a T3N1 rectal adenocarcinoma 5 centimeters from the anal verge. Completes TNT. On restaging, the DRE smooth, endoscopy shows a pale scar, MRI shows only fibrosis, no residual signal, looks like a CCR. The multidisciplinary team discusses watch and wait. What is the expected approximate local regrowth rate at 2 years in such patients based on the International Watch and Wait database? Is it A, less than 5%, B, 10 to 15%, C, approximately 25%, or D, greater than 50%?
Okay, based on the IWWD data for CCR patients on watch and wait, the expected 2-year local regrowth rate is around C, approximately 25%.
C, 25%, that's correct. And remember, most are salvageable. Okay, case 2. A 60-year-old woman, clinical T3N1 rectal adenocarcinoma. Tumor testing comes back. Mismatch repair deficient, dMMR. Given this specific finding, what would be the most appropriate preferred neoadjuvant treatment according to current NCCN guidelines? Is it A, long-course chemoradiation with concurrent capecitabine, B, short-course RT followed by capo-X chemotherapy, C, neoadjuvant checkpoint inhibitor immunotherapy like dostarlimab, or D, upfront surgery with adjuvant chemotherapy?
All right, key here is dMMR status. Based on NCCN guidelines and the data we discussed, the answer has to be C, neoadjuvant checkpoint inhibitor immunotherapy.
C, immunotherapy. Correct. Given the poor response to chemo and excellent response to IO. Okay, final case, case 3. The OPRA trial explored the optimal sequencing of total neoadjuvant therapy specifically for organ preservation, which TNT sequence demonstrated a higher 3-year TME-free survival, favoring the watch-and-wait approach. Was it A, induction chemo followed by long-course chemoradiation, B, long-course chemoradiation followed by consolidation chemotherapy, C, short-course RT followed by consolidation chemotherapy, or D, chemotherapy alone followed by surgery?
Okay, this tests the main finding of OPRA for organ preservation. The sequence that led to higher TME-free survival was B, long-course chemoradiation followed by consolidation chemotherapy. Radiation first.
B, consolidation radiation first. Exactly right. Great job.
Thanks. Those really hit the key takeaways.
They do. You know, these advancements in organ preservation are really shifting paradigms, but the concept itself, especially for the non-dMMR patients, it's still a dynamic area, right? There are ongoing discussions.
Oh, absolutely. While the quality of life benefits of avoiding TME are undeniable and incredibly important to patients,
Yeah.
we always have to weigh that against the known higher risk of local regrowth compared to surgery,
Right.
maybe around 25%, versus much lower after TME. And also the need for that very rigorous long-term surveillance.
Which is a big commitment.
It's a huge commitment for patients and for the clinical team. It's a delicate balance we're constantly navigating in shared decision-making, maximizing the chance to avoid surgery while ensuring we maintain excellent oncologic outcomes.
Right. Finding that sweet spot.
Exactly. However, the truly astonishing success of neoadjuvant immunotherapy in the dMMR group, that feels different. That represents a true revolution.
It really does.
This isn't just another incremental advance. It feels like a fundamental reevaluation of how we approach these specific patients. It's potentially rendering both surgery and radiation completely optional for a significant subset.
Making them optional.
Yeah, it forces us to reconsider the very definition of definitive therapy for dMMR rectal cancer, which is honestly incredibly exciting, a whole new treatment pathway.
It really is. Okay, let's try to summarize the absolute key points from today's session for everyone listening.
Sounds good.
First, non-operative management, or watch and wait, is a viable and increasingly preferred option for carefully selected patients, those achieving that stringent FDM criteria for clinical complete response after TNT. But it requires intense surveillance and shared decision-making.
Second, while an approximate 25% local regrowth rate is expected in these watch-and-wait patients within the first 2 years, most of these regrowths are endoluminal and can be successfully salvaged, crucially, without compromising long-term survival based on current large registry data, although we watch closely for distant mets if regrowth occurs.
Third, the OPRA trial gave us clear guidance on sequencing for 9-dMMR patients seeking organ preservation. A radiation therapy first TNT sequence, the consolidation approach, is superior, maximizing the chance for TME-free survival compared to chemo first.
And finally, fourth, the management landscape for dMMR rectal cancers has been utterly transformed. Neoadjuvant immunotherapy is showing unprecedented complete response rates, often 100%, establishing itself as a preferred and potentially definitive treatment approach, allowing many of these patients to avoid both radiation and surgery.
Excellent summary. FDM for CCR, 25% salvageable regrowth, RT first TNT for organ preservation, and IO revolutionizing dMMR care.
That captures it nicely.
Well, thank you for joining us for this really in-depth exploration of organ preservation and dMMR management in rectal cancer. Some truly practice-changing developments here.
Absolutely. It's an exciting time in rectal cancer treatment.
In our next session, we'll continue our discussion on rectal cancer management. We'll be diving into the evidence for potentially omitting radiation altogether for selected lower-risk patients.
The non-TNT approach for some.
Exactly. And we'll explore the trial that really looked into that, the PRO-SPECT trial, in detail.
Looking forward to that discussion. Prospect is another key trial to understand.
Definitely. For complete practice oral boards and more resources, head over to radoncSmartLearn.com. That's radoncSmartLearn.com. And be sure to subscribe to Rad on Smart Review for our next session.
Thanks everyone for tuning in.